I would like, pardon me, we will continue. Before we get started with the presentation, I just wanted to again say thank you so much to this group in particular for keeping our research going during a time of crisis and uncertainty, and to say thank you also to this group for really paving the way for the rest of NYU to reopen this past September. The purpose of our meeting today is, at your request, to give short updates on public health and research and how this will impact your community, and allow you to ask questions to me and to Carlo, who is joining us today as well. We are recording the meeting, as you just saw. All attendees should keep themselves on mute until we open the floor for questions. The chat, however, is live. It's being monitored by Christine Ponder on my team. If anyone has immediate responses to something that is being said or wants to make comments, and we're going to just say thank you again for all of your cooperation and your efforts. During the time of the pandemic, the research enterprise, by all measurable metrics, has been outperforming the university's sort of research history at any given time. So we've just been seeing intense activity in all disciplines, especially in the basic sciences, and anything that we can do to further support you is, of course, please just let us know. So I'm going to pass it over to Carlo to give you a short overview of the university's overall positive picture, what's been going on since we started testing and surveillance. As you know, we have a low positivity rate, and everybody can see the dashboard that's live, and I will pass it to Carlo to take it from here.
Hey, hello everyone, good afternoon, and thank you for the opportunity to come and discuss where we are with COVID over the current semester. You know, as Stacy said, I think, you know, inching towards the halfway mark of the semester, we are in a generally good place. We did a lot of preparatory work, and I think are thankful to the research community because in many ways they were the first to implement many of the policies, procedures back in the summer as the labs went back really to full swing, and got a lot of feedback. And certainly one of the things I want to express is that the constant feedback we get allows us to improve what we're doing. I don't think anyone went into the semester thinking that everything would end, you know, the same way that we started the semester in terms of process. The goal is to learn. I think we'll be looking at a lot of the same circumstance heading into the spring semester. Many of you have reached out with specific issues, general issues, and I think we've tried to be responsive to all of them in creating more efficient processes, safer processes. And I think that's been reflected in the fact that, again, at least through the first 6 weeks or so of the semester, we've had pretty stable positivity rates. They've generally been hovering about 0.4 to 0.5%. We've had somewhat extensive testing, as you all know, probably 12,000 tests per week. I think there's been very high compliance with wearing of masks and face coverings, high compliance with distancing, managing the daily screener. So collectively, I think it has put us in a good place. Again, we've had a couple of issues here and there. One of them being with the isolation and quarantining of students and residents, and just ensuring a more coordinated process with some of the students, where we are now going to roll out, hopefully next week, a new, what we're calling IQ coordinator sort of role, isolation quarantine coordinator, so that students have a single point of contact to navigate through and get their needs addressed. I think the ongoing testing program has worked exactly as we thought. It's allowed us to identify individuals who have been largely asymptomatic, isolate, contact trace, quarantine the contacts, and give us a very good sense of where the community is. We look at every single case, the living situation, sort of where they fit in the academic sort of environment of the university, to help identify whether we're having any significant increases in particular residence halls and particular departments, particular classrooms, labs, and with exceptionally rare exceptions, we've really seen no sustained transmission on campus. So, knock wood, that's been another positive sort of outcome so far that I think the widespread testing has allowed us to really get to, again, with limited. I think we've had maybe 2 cases, 3 cases where we've been able to identify 2 people who were somehow in close proximity, potentially infecting each other. One of those was potentially in one of the labs. Again, I think some subsequent testing cast some doubt on whether it was true, not true. We still grapple, I think, with the issue of false positivity, which is a challenge. And frankly, a challenge that gets magnified when you actually have a low prevalence on campus where a greater percent of your positives might be false positives. But again, collectively, I think the research community has been great in terms of being a partner. And I think collectively across the university and within the research labs, we've been in a pretty good place in terms of transmission and overall positivity. So I will stop there with that sort of overview of where I think we are so far.
So this meeting is really a forum for all of you to ask any questions or express any concerns that you might have about particularly the way things are going in the labs. Get clarification from Carlo on things like contact tracing, which I understand was a little bit of a question mark, or really any other sort of points of discussion around these subjects that are on your mind.
So Carlo, this is Dan Sains. I'm interested in why the university might or might not use the New York State COVID Alert app. It seems free and good. We've encouraged it in our department, and I understand, there's always limitations. People don't own a phone or operating system that may work, but the more people that use it, the safer we'd be.
Yeah, let me just take myself off of mute. We have been trying to vet contact tracing apps, from day one. And the New York State app is, I think, based off the Google Apple API, is my understanding. And as we have vetted that, including with IT at the university, I think one of the biggest challenges is there continues to be some concern about the validity of Bluetooth as a reliable marker of the distance time issue. So sort of compounding that concern is that if we were to get someone who, let's say, gets alerted, right, you were a close contact, we then have very limited ability to help navigate. Do we think that's a true close contact? Do we not? So we've been hesitant to fully embrace and advocate to say, hey, we're going to say this is the now app that we're going to recommend. My sort of review of the literature dating back to the spring is that the most effective times that this has been used are in countries where they can frankly violate what we would normally call sort of our privacy laws and allow sort of cell phone identification. I think Taiwan did that. Some other countries have done that. We could not do that here. Short of that, I think the data on whether or not the apps help or hurt is a little bit mixed. And it could be in how the studies are done. It could be in the app itself. But I think until we feel more confident in the sort of technical aspects of it, we've been hesitant to fully embrace it. With that said, I don't think we would say don't do it. We don't think it's so flawed that if someone were to say, hey, I'm going to encourage my class to do it, not mandate it, but encourage it, encourage the lab to do it, I think that's 100% a reasonable thing to do. Again, we as a COVID prevention and response team will be a little bit more handcuffed if someone comes back and says, hey, I was noted to be a close contact, what should I do? Then it's a little bit harder to navigate that because we won't know what the close contact was based on. That being said, my understanding is, and this I don't know for a fact, this was shared by others with me, the city and state health officials might come and actually say, oh, and by the way, it looks like you were a close contact, and sort of delve into wanting to know more about your cell phone, your app data at that point, which again, I don't know whether that's 100% true or not, but I think we're hesitant to open up with a formally endorsed app, then other people coming in to sort of inquire about your contacts might have been. So again, a full-throated endorsement we've been hesitant to do. Sort of a, if you want to say for the, your lab that you want to use it, I think it's probably okay. We just can't give it that sort of full university endorsement based off of what we know so far.
I've got a question about contact tracing again for Carlo. So it's my understanding from looking at the literature that research is showing that COVID is mostly spread not by most people who are infected, but rather by a small fraction, super spreaders. So in other words, most people who get infected don't infect anyone else. And the person who infected most of the infected cases likely infected many other people. So if that's true, then it alters the best strategy for contact tracing. That instead necessarily of tracing down the contacts of every infected case, it makes more sense to take a step back, learn who infected them, and then trace that person's contacts because they're likely to be a super spreader. So I'm just wondering, is that being taken into account? Is that accurate, and is that being taken into account in our contact tracing efforts?
So you're right in that the literature is growing that, it's sort of, I don't know if it's exactly 80-20, but sort of that 80-20 rule of it seems that 80% of cases are tied back maybe to 20% of the people. I do think that we remember as part of contact tracing, you do sort of go back with people and say, where were you? And we, at least when I do the analysis, go backwards. So for example, and let me make this up, if I see that I've got now 2 people or 3 people this week in a tandem computer engineering lab, I may go back to say, did anyone else, a week, 10 days ago in computer engineering, and sort of cross-match those class lists to be able to sort of go backwards and say, was there someone else who was positive, who might have been the sort of super spreader? The challenge is, by then, presumably that person has already been isolated. It's more, I don't know if it's reassuring or validating that this is what's happening, but in theory, rapid identification and isolation should mitigate some of the super spreading. And again, I think what we've done, and knock wood, not only have we not had super spreader events, we've had little evidence of just any transmission, in part. And every time I get on with student affairs, the push-pull is we've basically allowed no one to do anything this semester, at least students, in terms of gatherings. So I think we, at least in a formal way, what happens informally, obviously, where we don't have control is a little different. But because we have been so restrictive on gatherings, I think we've at least reduced the likelihood of a super spreader event. And I think if you read about them, and let's face it, the White House is the perfectly recent example of a super spreader event. When are those more likely to happen, right? No mask wearing, minimal adherence to social distancing, a lot of loud talking and, shouting. And we have tried to really eliminate some of those risks by the policies we've set up. So I think your premise is 100% correct. I think we have set our policies up in a way to minimize super spreader events. Can I say we can guarantee that we won't have them? No, but I do think that we've set up our policies and protocols in a way that does really mitigate the risk. And also, again, by reducing class size, reducing, any sort of gatherings, at least in a formal way, we have done everything we can, I think, to minimize super spreader risk.
Thank you.
Go ahead, Eric.
Actually have a couple of questions. Some of these might be better directed at Stacy, but one question for you, Carlo, is this came up at our science chairs meeting today. Can you tell us what the false positive rate is for the saliva kits?
So it's an interesting question, because one of the challenges is it's sort of twofold. One is anytime you're trying to figure out false negative, false positive, you have to do it against a gold standard. So what's the gold standard right now for, COVID infection? You know, is it viral culture? Is it, and as you know, every single test on the market right now did not go through the normal FDA process. So sometimes we get criticized because people will read the Bing stuff and say it's not FDA approved. There is not a single test on the market now that is officially FDA approved. They all have emergency use authorization, which means they went through much more limited testing to get that. You know, and even looking at the EU that Bink's got, it is much more limited than I think you would see in a normal setting where you would probably test thousands, tens of thousands against some gold standard. So I don't know what the original gold standard was. You know, did someone get emergency use because they compared PCR against viral culture or something else? Right now, PCR is the gold standard against which other tests, so for example, the rapid antigen tests are compared against PCR, with PCR serving as the gold standard. The saliva tests are processed through, you know, it's a PCR test like the nasal swab. They got their emergency use through the same process every other test has gotten it. The challenge is we don't really know what the gold standard is. So, you know, the best guess on false positivity rates is, you know, anywhere maybe from 0.1, 0.05 up to, you know, maybe a couple of percent. And I think the challenge for us is, let's even assume, you know, maybe 0.2 or 0.3% false positive. You do 10, 12,000, even 13,000 tests a week at 0.2 or 0.3%, that's 20, 30, 40 positives a week, which is probably the majority of what we're seeing right now. You know, even the week that we quote unquote went over the case limit, I think we just went over, you know, so 100 cases, if 30 or 40 are positives, you know, you're talking about, you know, a positive predictive value of just over 50%. And that was a bad week. Most weeks we've been, you know, 70 or 80 cases. Last week, we actually were remarkably way below that. We had a great week last week. So how many of those are false positives? I think a substantial number. The problem is, and the other thing that I would say confirms that, or at least validates it to a degree, we are estimating that probably 70% of the people who are testing positive are asymptomatic. And I think if you look in a young adult population, maybe 30 to 40% are generally asymptomatic. So, you know, do we think that maybe about half our cases are false positives? It could be. There's no way to know though, because again, what is the gold standard that we're comparing to? And then the challenge is, even if we were to set up an internal protocol to say, hey, we're going to validate every positive by doing, you know, another test afterwards, once a positive report gets reported to the Department of Health by the lab, we are stuck treating that as a positive, which, you know, unfortunately causes some angst for the people who, you know, are both asymptomatic and on their own have gotten repeated testing that's negative. We are stuck telling them, you have to now isolate and quarantine because the Department of Health has a positive result. And we've had all sorts of discussions with them about what we can do to sort of perhaps mitigate some of that. And for some of our students, it was really problematic because many of them had just finished a 2-week travel quarantine, sort of were engaged in campus activities, and then maybe had a roommate who tested positive, and now they're back in quarantine. And, you know, they'll have to say, well, I think it's a false positive. And the best we can say is it might be, but unfortunately where we are today is having to treat it as a true positive.
And then my other question for you, Carlo, and this is probably for Stacy also. We're getting a little bit of mixed messages regarding the amount of testing that we can get. So some of the people in our department would like to have had weekly testing, but I understand, you know, the immense cost this is to the university and why you can't have everybody on campus tested weekly. But I would like some guidance about this because it comes up so often in discussions with faculty and postdoc students and staff.
Right. So I'll start, and then Stacy can certainly jump in. I think we started with a certain strategy, which was what we thought was a risk-based strategy, that we thought certain people were, more likely to be at risk. And we thought that those were our residential students. They lived in a much more, you know, sort of congregate setting, and started the semester with testing students and residents weekly. We've encouraged a few student groups who are doing clinical rotations to also test weekly, and everyone else test every other week. I think where we've gotten to, and we kind of wanted to see where we were after several weeks, it looks like our residential students are not really testing at a rate any higher than anyone else. Again, we're seeing little transmission in the residence halls themselves. We probably do think that some of these clinical settings might be higher risk. Just in some conversations I've had with people in the labs, although we say we're socially distancing, some of the setups in the labs maybe don't lend themselves to consistent social distancing. So I think we were open to having conversations of where we might shift to weekly testing. I think we've been hesitant to just say, okay, blanket, this group now tests weekly, because at least for the first 2 or 3 weeks of testing, while I wouldn't say we had supply chain issues, I think we had sort of just-in-time supply of test kits. So we didn't want to have people running out and getting stressed out that it was my week, I went to the site, I couldn't pick up. I think that we can revisit where we think the risk is. And let me just say, the risk isn't just your risk of getting infected. You know, some of the conversation that we've had, I know that I had with Dan and others during the summer, was the risk if we have to close a particular area of the university. So if we think research labs, by nature of the work and the investment of dollars of shutting them down is high, to me, that's legitimate risk that needs to be taken into consideration in the testing strategy. Again, I think that we wanted a few weeks of testing results just to get a sense of where that is. And again, and you all know better than I do, but my sense is in looking at the data right now, the research labs from a transmission point of view don't look higher. But if we think there's risk because, hey, shutting down a lab for a couple of weeks, and we had to do that in one lab because we had 2 cases in one lab, that's disruptive. And I think I get that. Now, let's balance that against the prior conversation. If we think we're still running high positivity rates, testing every week then increases your likelihood of a false positive. So I think, you know, that's what we're trying to balance collectively in terms of some of the policy making. And again, I invite open discussion among this group where we think that balance is right. And if we either want to, for specific labs, because we know just by the size, the nature of the interactions, we want to go to weekly, that's a conversation to be had, against the risk of, you know, once we get a positive, we are sort of stuck in a, okay, now we have to contact trace. Now, if we get a second case, we might want to shut down the lab. So, you know, all of those are factors, which is probably why you hear mixed messaging, because there's rationale, I think, but I don't think we're ready for a blanket policy statement to say, let's have all the labs test weekly.
Can I just jump in for 1 second? Hi, Carlo, this is Bobby. We talked a lot on the phone because my lab is the one that had 2 positives. And as it turns out, they were both false positive. So one of the things I would really love to see NYU do, and I think all the protocols that were followed by NYU, and Carlo and I talked many times on the phone about this, were really great, because if somebody is positive with saliva, you have to isolate that person for 10 to 12 days. What would really help, and this is one thing I would beg the university to do, is actually get that positive person to be retested at NYU Medical School or Langone. Because the problem we had is that our students, my students, went to CityMD, and they take 5 to 6 days to find out what's going on. So they kept on going back to CityMD, kept on getting negative, and we didn't know what to trust, and they were asymptomatic. And there's an emotional cost. It's not just those people sitting at home and not doing work. It's just they don't know how to handle their parents. They don't know how to handle their, you know, spouses, you know, parents, things like that. So it would just really be good if we could get a quicker retesting with nasal, because we still don't know how good saliva is. So that would be still my only request, you know, and I love the fact that we can reach out to Carlo at any time, and you know, he's always there to be able to talk us through this. So thank you for doing that.
No, absolutely. And I think, as you said, we had several conversations, and I think the challenge right now is we don't have the discretion from the Department of Health to sort of ignore a positive test, even if we get an immediate negative test result. So some of the things we've been working on with the lab is...
But we're not talking about ignoring the positive. We're just saying, So those students can still be isolated for 12 days. It's not about bringing them back to work. It's just knowing whether the the saliva is correct or not. Just getting a more, better test just for their emotional toll, not the work. I think.
Yeah, I mean, I think we can certainly do that. I think what we've seen is it sometimes just creates more confusion and sort of anxiety because then they don't know what to believe. And there is also, I think the time frame issue is a valid one because the longer you go out, then it's, hey, were you positive when you tested, but now, you've cleared it, 4 or 5 days have gone by between samples. So we're working both with the lab, thinking through, are there ways of more rapidly getting results back so that we could do some confirmatory testing, and with the Department of Health to say, let's say we establish our own protocol that within 24 hours of a positive result, can we retest and, whatever. And we said, basically, whatever protocol you want. Of course, there's a dynamic, as many of you know, between the city and state that is more political than it is evidence-based. So there's also that to navigate. I think in an individual case, if it makes someone feel better to go get tested, we'll certainly try to accommodate that. Langone generally has not been open to us sending students. So for students, we've been trying to find other places for them to go for more rapid testing. And what we don't want to do is open everyone up to get retested. Again, I think that we are trying to look at what is the false positive rate, and what do we base that on? Is it just on retesting, which again is hard to do because again, you could be positive one day, negative another day. Which one do you believe? Have you cleared sort of low levels of virus? Exceedingly difficult to assess. But again, I would say that we are sensitive to the false positive issue and looking at 2 or 3 things that we can do to mitigate at least some of the impact, because it's, I think, had significant impact, on the labs, on students in quarantine, in the residence halls, for our own reporting to the state. If 50% of our cases are false positives, I'd love to take that out of the equation of what we report, publicly. But right now we are a bit stuck with it from a procedural point of view, not so much from an emotional toll point of view.
Mark has patiently been waiting with his hand raised. Do you want to jump in?
Thanks, Christine. So either Stacy or Carlo. So I was wondering, what are the procedures for faculty quarantining? So let's suppose I get a positive test, or as could be, the case with me, I know I'm going to have to travel to a COVID hot zone. So I'll know exactly when I'm going and when I'm coming back, and we'll have to quarantine after I do that. Should we, I don't know how this works. I don't know how many, and I can't quarantine at home, let's say. So I know you have some spaces reserved for that. But what happens if they're not available, or there are, but do I have to reserve in advance if I know I'm going to be traveling somewhere? So are there sort of general rules and guidelines for this?
So, what'll happen is if you test positive through sort of the ongoing testing program, someone on our team will reach out. And if you're positive, one of the first things that we'll ask, are you able to quarantine isolate where you are? I mean, overwhelmingly, most people who are not in a residence hall in a shared bedroom will be able to. I think for those who can't, there are sort of options that the city has. And I will say, we are exploring, although I don't know where we are, with potentially offering some of the spaces we have for students to faculty if it is really deemed difficult for them to isolate at home. I don't know where that has landed as an official policy decision.
Mm-hmm.
But I know there was discussion within the provost's office about potentially offering that. It's been rare, but I think reassuring people to know that option was there. I think there was some, I won't say anxiety, but concern that, as we get further into cold and flu season, the other thing we're going to run into is when someone is symptomatic, then it'll take a day or two to definitively know. So if you've got 2 students sharing a room, there's going to be a lot of kind of in and out of isolation and quarantine till we know for sure. And we have a fair amount. We have several hundred beds reserved for that. But are we going to begin to inch up on capacity? But the issue that you raised has come up. As of today, I don't know that the university officially has space, but I think we would always take every case as a case-by-case situation. And if someone legitimately said they couldn't, we would one way or another find a way to find an isolation spot for them. And I think same with quarantine. If someone knew they were going to a quote unquote hotspot and then coming back and absolutely said, just by nature of my living arrangement, I can't do it, help me find somewhere, whether that's a city resource or a university resource, we would work with you to find the space.
Great, thanks.
Any other questions or raised hands? Eric?
Stacy, this is for you. Are undergraduates allowed to work in the labs? I know there are classes that were originally allowed that if they were being paid or if they were taking it for credit, but many of our undergraduates do work in the lab just as volunteers. And of course, this is important for their applications for graduate school or medical school, et cetera.
Yeah, so it's a really good question. The answer has been evolving over time. And so I thank this group for your patience because originally there were no undergraduates allowed in the lab. Then when the essential workforce was officially sort of welcomed back, including health and defense related work, we were allowed to include undergraduate workers who are compensated in the laboratories back in. And we are also at the point now, Christine, correct me if I'm wrong, any undergraduate who is working for credit can go back into the labs as well. We are still trying to discourage undergraduate volunteers just simply to keep density down, and because we had assumed before we had the results from the previous weeks of testing that the undergraduates were the most vulnerable population who could potentially bring the virus into the laboratory space. So certainly if they're receiving academic credit or if they're paid in any sort of way, they are welcome to return. Yes, David.
Thanks. I actually have a question for Carlo and a question for Stacy. So firstly, for Carlo, I was wondering, many of us actually live in the faculty dormitory, and I was wondering if was any thought to extending testing of the NYU community to NYU families, particularly those who live in Washington Square Village and the Silver Towers, who are coming into work every day.
So it did come up for conversation, and I think a policy decision was made not to include them. I think it gets a little bit tricky in terms of who we include outside of the program. So right now we've only included people who are either faculty, staff, or students as the community that we're testing. I think we recognize that there is other exposure that might exist, but for now, we are only testing employees, faculty, and students, in part from a risk perspective, because we have responsibility for those individuals. And if we had a positive result, have mechanisms to address it. If we were to have, let's say, a minor test positive who's a family member, what's our then clinical obligation to intervene? And it sort of creates a little bit of a risk issue for the university, understanding that there's also still some risk with sort of not testing. So while we encourage everyone to get tested who potentially lives together, we've not included families in the at least initial strategy for testing.
And then I guess my question for Stacy is that, you started by saying that research output has actually increased. I think maybe that's based on papers and grants that many of us were planning to write, and then were given the opportunity to do so under lockdown. But my concern is sort of the long-term prospects, because especially for labs that are data generators, and I just wondered what the thinking was about there. And I guess, my understanding is that the current approach is that people are welcome, researchers are welcome to come, but they're not compelled to come if they don't choose to. And I wondered if there's any evolution in thinking about that.
Yeah,
Or-
so there's a lot in that question, and this is something that I think about all the time. What are the long-term impacts on our research enterprise as a result of the pandemic? It's not a simple answer. I can tell you that earlier today, we had a call with the NIH. They put out a very large survey to institutions like ours to try to assess that. We're talking with the AAU and with other universities, our peers and competitors. And so far, a lot of sort of the Carnegie R1, right, the top research producing universities have maintained research expenditures, grant portfolios, productivity on paper. I definitely worry when we're looking 3, 6, 9, 12, 18 months down the line, what the impact of this will be on us. And I don't have a clear answer for you. In terms of mandating whether people must return to the university, within the research enterprise, the university has determined that anybody who requests an exemption through OEO may be granted that exemption. And so we can't carve out the research population as, a set of essential employees who must return to work when the parameters for that accommodation process really encompass the whole entire community. So I'm not sure if that's a satisfactory answer, but that's, sort of where we are. I will say that as a university, we are lobbying the federal government as hard as we can to get research stimulus funds. So there are different packages that are floating around right now, stimulus packages that are especially designed to support the research workforce, graduate students, postdocs who are going to be very negatively impacted by the pandemic and their job finding opportunities. We have a person in the research on my team now who is in the DC office, and that is basically all he's doing, and we're keeping an eye on it. As this president, potentially winds down, hopefully winds down, a lot of those conversations are very much up in the air.
I just think, I do think your team and Carlo have been hugely successful in the reopening of the labs, and it's been done really well and done very safely. But I just wonder whether that's being conveyed to people who are still hesitant to come back. And I'm not sure what the solution to that is, but the labs are actually the safest place to be in New York City, probably because they're the lowest density places in New York City at the moment, as far as.
Yes. So for Carlo and for me, we knew that the labs were going to be the safest place to be. We never closed the labs. The labs came back to work, on June 8th officially, and have been safe this whole time. We are so grateful. It was not us who did anything. It was really all of you who took precautions and took responsibility for setting a precedent. I think about how we were flying blind during a time where incidence of the disease was so high. We were not doing any testing in June and July and August unless you were getting tested on your own. And so, there was a lot of courage and bravery there and a lot of trust in each other and your community. And my hope is that, as a grassroots effort and on the ground where you are locally, you can convey that sense of safety and security. I don't know if it has as much impact coming from me or from Carlo as it does coming from you guys on the ground in and out of the labs every day, and hopefully encouraging people to take that chance. I see that Tanya has a question in the chat about what the plan is for the research labs if the university goes remote. So of course you all know that working with New York State, there is a threshold after which we cross over that the state will want us to go remote. Carlo has been working really effectively with them in sort of recalibrating that threshold really according to the logic and the sort of reality of our situation, geographical dispersion of our different schools and campuses. But for the purposes of this discussion, should that happen and the university needs to go remote, we specifically carved out the research community from that so that the labs would be able to maintain activity and your work would not change.
Thank you very much.
And that was really based on my discussions with universities that had massive, crazy outbreaks of COVID on campus. Other vice provosts for research were not seeing that transmitted into the labs. And so we felt pretty good about, about NYU and about trying to keep you guys safe.
There's an add-on to that question in the chat about, will people who have been declared essential keep their statuses, or will it have to be reevaluated, especially for essential researchers?
Yeah, so we define for ourselves what we consider essential within the research community. The state considers all health and defense related work to be essential. That can continue even if the whole state shuts down again like it did. And so for us, health and defense related is a very broad overarching theme, which we can apply pretty broadly. I mean, among this group, there's no one who wouldn't fall into it. So I don't think we would have to reevaluate. We would use the same sort of criteria that we used when we reopened on June 8th. All right.
I've one more
Anyone
question.
else?
Yes, this is Dan Sains again. One more question for Carlo or Stacy. Do you have any position, or are there any regulations about how we can use or should use New York City testing? And the reason I ask is my son went to a rapid point care of testing facility yesterday in Far Rockaway, got a swab test, and he got his results in 2 hours.
So I think that we have been thinking about using the rapid testing more for higher risk situations. So people who are symptomatic or sort of high risk exposure, where we might want to know sooner rather than later. So we do have the ability on campus for some rapid testing, but that would be largely for people who are symptomatic, not for surveillance as much. I think one of the challenges is, for us with surveillance, we want to make sure that the data is flowing back to us pretty consistently and quickly, so that we can sort of track people and identify them. If we have people going to multiple different sites, it then becomes very difficult to pull that information in. We did that during the gateway testing, and it proved to be logistically challenging, I think, just to keep track of the records. So for surveillance, ongoing testing, we're trying to stick to the single sort of lab. For rapid testing, because someone is symptomatic, we've actually set up testing on campus to do rapid testing. And as we get into cold and flu season more, I think that will become a more critical arm of what we've been doing. As I said, up until now, it's been largely asymptomatic people who have tested positive. I suspect the needle will shift on that as we get deeper into the semester. And actually, to Dan's, just to that point, people aren't on campus every day. So if you're symptomatic at home and you're like, wow, I want to know, and you go and get tested, which I would encourage everyone to do, and you get that rapid test result back, we have a form, a self-reporting form, that you then would report the fact that you tested positive, and you'd effectively get the same response back from the team who would do the evaluation, ask you to isolate, contact trace. So it doesn't completely fall out of the system, but for pure surveillance purposes, we're going to try to stick to the big saliva testing.
This is Pat Schrott. I just listening to this conversation about
Can't hear you, Pat.
You're muted.
I think you're having some issue with your microphone. It's not just the muting.
can you hear me now?
Mm-hmm.
Yes.
Okay. So I was just going to say, if with this low false positive rate, but it's a real false positive rate, if someone doesn't have any symptoms and they are picked up in their surveillance, it seems, just for everybody's sake, it would be good to arrange an immediate follow-up for that person, and to at least keep track of what is a likely false positive, because all of us who, when we get our results, we should be able to understand the complexity of this situation. So when you said, gee, if we do more, you wouldn't really know what to make of it, that sounded a little bit like our president, that we should do a little less testing because we might get some more false positives. If someone is positive and also has symptoms, then you don't need further tests. You just need to take care of that person. But anyway, I think you should rethink that policy.
Well, just to be clear, I don't think that with 12 to 13,000 tests a week, I could be accused of not wanting to test aggressively. So I think what we're trying to do is line up testing, right? I think it's sort of, the old Bayes theorem, your pre-test probability, you want to be high so that you are reducing your false positives. So I think what we're trying to do is aligning our testing where we think the greatest risk is. And I think my only point earlier about the labs, if we don't think the labs are any higher risk, then increasing testing there potentially only increases false positives and doesn't get us to a better place in terms of reducing transmission. So I think wherever we think there's an opportunity to test more, I'm 100% willing to put the resources there. I just don't want to increase testing in somewhere where we don't think the risk is higher, especially in the setting of false positives. On retesting everyone, I think one of the things that we propose to the Department of Health is actually very similar to what you said, which is someone is asymptomatic, no identifiable contact. Could we rapidly retest and sort of, then declare that they were a false positive? They didn't buy that. So again, we're sort of stuck from a process point of view as treating them like a positive result. I would rather set up a process where we actually get some benefit from the retesting rather than sort of additional angst of, what do I believe? And I think the rapidity of testing is something that we need to think about, because once a certain period goes by, then it becomes difficult to say that, somehow in the 2 or 3 days, you've not cleared the virus. So part of this also gets into lab protocol of what they're willing to do within the lab and what they're capable of doing.
So I see another question from Tara in the chat. Is it still voluntary to come back to campus for researchers, or do they need an approved OEO accommodation to remain remote at this time? So there are a lot of categories of researchers, and there's a question that is going to have a different answer for different categories of researchers. So for faculty, for sure, have to request an OEO accommodation. For people who work in the labs as sort of like lab technicians or lab managers, that is a totally different kind of process where we are allowed to give them advance notice that they must return to work. If they don't, there are consequences, including termination of the position, and you can work with your HR officers on this kind of an issue. So it really depends upon the classification of researcher. We had a lot of flexibility in salary support on especially federal projects during the pandemic, but that flexibility expired on September 30th. And so even if people didn't have time and effort on federal grants, we were still allowed to pay them. That is no longer the case. And so that, of course, is going to have an impact on anyone whose salary is supported, especially by a federal award. Those people really do need to put the time and effort on the grant that was promised in the budget. And so I'm happy to have a separate conversation with you about all of these different categories of people. All right, so I think we're winding down. I'll give it 3 seconds to see if there are any last questions, but we're approaching the 4 o'clock hour and hopefully the end of most of our days. I don't mean our days, I just mean today's day of work. All right, so I don't see any hands. I want to just say thank you again to this group for your tremendous partnership in bringing our university back online. It is because of you that we are able to have a hybrid learning model this fall. I want to say thank you to Christine. She has done an unbelievable job working at home with little kids, carrying the weight of all the operations and logistical support. I want to say thanks to Carlo. No one at this university has cared more about bringing this community back safely than this man. He has worked tirelessly. He is on every Zoom. I see his face when I close my eyes at night. He is an angel. He is really sincere about being partners with you as we move forward and as the situation evolves. He is really willing to do whatever we need to make sure that we feel safe. I want to say to this group, please keep doing exactly what you're doing. Make sure your people are protected, make sure they're wearing masks, they're social distanced, they're in and out of there, you know, really the minimal amount of time, and vote. And thank you. Bye, everybody.
Thank
Bye-bye.
you.